Hello everyone, welcome to the 7th episode of the Differential podcast. In this episode I'm going to be discussing with you thyroid function tests, how to read them, and how they will differ in different pathologies. My objective from this episode is not to cover hyperthyroid versus hypothyroid symptoms and signs, however or even thyroid cancer. My purpose is to cover thyroid function tests and how they could lead you objectively into the diagnosis. And I will touch a bit clinically on thyroiditis just because it can be a headache. So, you look at thyroid function tests, the easiest way is to differentiate full-blown hypothyroidism from full-blown hyperthyroidism. In hypothyroidism, TSH will be high, T4 and T3 are low. In hyperthyroidism, T4 and T3 are high, TSH is low. And that's when it's a primary pathology of the thyroid gland, whether we're talking about a multinodular goiter or Graves' disease or a hot nodule, or we are talking about, when discussing hypothyroid causes, Hashimoto thyroiditis, among other thyroiditis causes, or even total thyroidectomy, iatrogenic causes. So all of these are primary thyroidal issues. However, it could be a pituitary issue or hypothalamic. So if someone has a central issue resulting in hyperthyroidism, you will have high TSH, T4, T3. The opposite when it's hypothyroidism, where all the labs are going to be low. So this makes sense. It's like the relationship in the adrenal gland with corticosteroids and ACTH. It's endocrine, right? This is the easy part. Now, there is a clinical entity which we call subclinical hypothyroidism and subclinical hyperthyroidism. And this is not, although the name says subclinical, this has nothing to do actually with the symptoms because the patients might be symptomatic and that's an indication to treat them. It has to do with the labs. So when we say it's subclinical hyperthyroidism, this means that the patient is hyperthyroid. However, there is too many reasons I have a problem with this name. Because first, subclinical, but the patient could be symptomatic. The second thing, we say hyperthyroidism. However, the T4 and T3 are normal. So they are in normal range. However, what's really going on here, that the negative feedback from thyroxine elevation, which is the hyperthyroidism, suppressed TSH, so TSH is low, in a way that managed to compensate the elevation and bring it down. So, how you could remember this? So, T4, if we could imagine it as a story, T4 and T3 went up. They suppressed TSH. And the suppression in TSH managed to contain T4 and T3 within normal range. So, TSH is low, T4 and T3 are normal. This is just pending full-blown hyperthyroidism. The pituitary will not be able to continue suppressing. The suppression of TSH will not be sufficient to bring T4 and T3 to normal level. That's when it becomes hyperthyroidism, full-blown, not subclinical. So again, subclinical hyperthyroidism, your TSH is going to be low, consistent with full-blown hyperthyroidism. However, T4 and T3 will be normal because the drop in TSH managed to bring them down to normal instead of being elevated, but that could eventually become full-blown hyperthyroidism, and T4 and T3 will be out of control and become high. So that's why we call it subclinical hyperthyroidism. And there is also subclinical hypothyroidism, where TSH will be high and T4 and T3 will be normal. So imagine that T4 and T3 started to drop, TSH was alerted, went up, and now it's able to compensate. However, at any moment, the thyroid is no longer responding to that TSH. It's burned out from the inflammation, from the destruction. So T4 and T3 will fall below the normal range and TSH will be high. So that's subclinical hypothyroidism. All right? Now, thyroiditis. Thyroiditis could go through multiple phases where you're going to have hypothyroidism and hyperthyroidism. Initially, you're going to have hyperthyroidism because with thyroiditis, it's an inflammatory process. This will cause the destruction of thyroid cells, follicular cells, and the release of thyroxine. So initially they will be hyperthyroid, then they will become hypothyroid, then back to euthyroid or permanently hypothyroid if they don't recover sufficiently. So what are the types? First, Hashimoto. Hashimoto itself is Hashimoto thyroiditis. However, this one is permanent hypothyroidism. So once it takes place, thyroid is no longer functional. And they are going to have positive TBO, which is the anti-thyroid peroxidase antibody. How about the radioactive iodine uptake in Hashimoto thyroiditis? It's going to be low. It could be variable, but generally speaking, it will be low. Now that's Hashimoto thyroiditis. And they are going to be hypothyroid. Now there's two other types of thyroiditis, which are painless and subacute, which is the D-quervin. Now the painless thyroiditis, from the name, painless or silent, that's how they call it, they are going to have a painless neck. Their neck is not going to be tender. They don't have tender neck. This is really very important. They don't have tender goiter. They don't have that neck pain. It's going to be really very simple, where they will have a hyperthyroid phase, then they are going to have, following it, a hypothyroid phase, and then they are back to normal and they recover. It's really very simple. Will they have a positive thyroid peroxidase antibody? They will. And how will the radioiodine uptake look like? It's going to be low because it's inflammation. These cells are being destroyed. They are not taking iodine. They are not functioning properly. The initial hypothyroid phase is because of the release of the stored content. It's not because of them taking iodine. And this helps differentiate during the hyperthyroid phase from Graves' disease. So that's painless thyroiditis. Actually, I looked it up online and read about it. It looks like a sub-entity of Hashimoto. Like, it's someone who is, like, it looks like it's going to be Hashimoto. They have the antibody. It's painless. They have a goiter. It's not tender. Maybe not a goiter necessarily, but like their thyroid is non-tender. And they have a picture of hypothyroidism. Maybe they didn't present in the hyperthyroid phase. So they are hypothyroidism. However, they will recover back to normal. Not like Hashimoto, which is going to persistently stay hypothyroid. Okay? Now, the subacute thyroiditis, or the quervin, this one is what happens after viral infection. So ESR, CRB will go up. Again, low radioactive iodine because it's thyroiditis. It's inflammation, it's destruction, there is no iodine uptake. And they will have the hyperthyroid followed by the hypothyroid, followed by the euthyroid, possibly. It's the same. However, what differentiates here, it's post-viral, the subacute or the quervin. It's post-viral, CRB ESR is up, and there is neck tenderness. So it's like an infection. So you could think of it this way. Okay, so that's subacute thyroiditis or the quervin. Painless is kind of Hashimoto that recovers. Hashimoto is permanent. So is thyroid peroxidase antibodies positive in subacute? They are not. They are only positive in painless and in Hashimoto thyroiditis. Now, amiodarone and lithium, that's another thing I wanted to touch on. And you will find like different ways at which they could affect the thyroid gland. They could lead to hypothyroidism, they could lead to hyper, they could lead to some problems with peripheral conversion of T4 to T3. So actually don't memorize them. The way the question will come is that someone has bipolar disorder and they will try to hide lithium, or someone has a psychiatric history and this and that, they will try to hide it in the question. So what was the cause for this thyroid derangement? It's lithium. And if someone has lithium-induced hypothyroidism, you don't stop the lithium because it's a very important medication for their symptoms. You just start levothyroxine. So that's one question I remember seeing somewhere. And it can cause also hyperthyroidism. So it really varies. Amiodarone is the same. So someone has an arrhythmia, they take multiple medications. Amiodarone can cause the same problems. Hypo, it's really a mess. What you need to know is to identify that it's a medication adverse effect, or they could give you a long scenario and they will drop amiodarone there somewhere, maybe even hide it, tell you that he have multiple comorbids and he takes an antiarrhythmic medication, or he takes medications for arrhythmia. And again, the same concept applies to lithium in psychiatric disease. And eventually, the idea is, what will you send for this patient? It's going to be thyroid function test, because they will have weight gain, maybe some depression, maybe some bradycardia that they will mention within the heart rate. So they will really try to hide these features that suggest hypo or hyperthyroid, or generally speaking, thyroid dysfunction. So pay attention to these two medications. Levothyroxine and pregnancy is another thing I wanted to touch on. Once someone becomes pregnant, their levothyroxine dose must be increased. I remember by 25 to 50%. You could look up online the exact percentage. However, I remember a question in New World, I guess. The whole concept is that you know that levothyroxine must be increased in dose once they start their pregnancy, once the pregnancy is confirmed, and not before. Okay. Now there is one entity I didn't mention, which is the sequiothyroid syndrome. Sequiothyroid syndrome happens when someone has a critical illness. So sepsis, coronary artery disease, ischemic events, and you test their labs, you find that TSH is normal, T4 is normal, T3 is low. So the peripheral conversion of T4 to T3 was impaired because of this shock, because of this major critical event that happened to this patient. Just know the pattern, that's it. Now, lastly, I will speak on thyroid-binding globulins impact on free T4, total T4, and TSH. And this is really important because sometimes they will test this concept. So if someone is taking oral contraceptives or they become pregnant, so their internal estrogen is high, these individuals are going to have increased production of liver proteins, which include clotting factors. That's why OCPs in pregnancy raise the risk of coagulation or thromboembolic events. In similar way, it will increase hepatic production of thyroid-binding globulins, meaning more of thyroxine, internal body thyroxine, is going to bind with thyroid-binding globulins. So total thyroxine or total T4 will go up. However, the free amount is going to be normal. And for our pituitary gland to stimulate the thyroid to produce more thyroxine, because more will be bound and we want to maintain that free within normal range, then you expect TSH to move up. It's a compensatory mechanism. So I have more proteins binding more thyroxine, so the free did drop, meaning less feedback to the pituitary, so pituitary will boost up TSH production to compensate, raising all overall thyroxine production. It will bind to the hepatic protein TBG, and the free will come back to normal. So normally free, total is increased, TSH is increased to compensate. Or it could be normal as well, which I have read. So it could be normal to elevated TSH. Okay? The opposite will happen when thyroid-binding globulins drop. And that's what you see in someone who has cirrhosis or nephrotic syndrome, where they are losing proteins. So they lose the TBG, which means there is no protein to bind thyroxine in the body. So I don't need that much of stimulation to the thyroid gland to produce thyroxine. Like little TSH can produce sufficient amounts that are normal, speaking of the free thyroxine, because it's not being bound to proteins, and a very small amount of it is sufficient to produce a negative feedback because there is no protein bound, which is inactive because I'm losing the protein. So the total will be reduced, free will be normal, TSH could be normal to low. So that's what you expect to see when there is a condition that increases or decreases TBGs, as discussed. These are the things that I wanted to mention about thyroid function tests. Definitely, if you dig deep, there's more details with thyroid malignancies and biomarkers. However, I wanted to keep it brief. Just take this into your mind, and yeah, best of luck on your preparation, and see you in the next one.